Hi, everyone. My name is Jessica Shenoi. I'm a second-year medical toxicology fellow at Emory University School of Medicine. Today, we will be talking about bomb-related injuries. This is part of our Global Clinical Toxicology Series. And with us today, we have Dr. Ziad Kazi. Dr. Kazi, would you like to introduce yourself?
Yes, Dr. Shenoi, thank you for having me, first of all. My name is Ziad Kazi. I'm a professor of emergency medicine and medical toxicology here at Emory University in Atlanta, Georgia, USA. I'm also the assistant medical director of the Georgia Poison Center and the associate medical director of the Southern Regional Disaster Response System. Um, I also hold an adjunct professor appointment at the American University of Beirut Department of Emergency Medicine, and I'm the current director and past president of the Middle East and North Africa Clinical Toxicology Association. I'm also the president of the American College of Medical Toxicology.
Thank you so much for being here. So to start off with our bomb-related injuries, let's talk about blast injuries. What are they and what are the different types?
Basically, blast injuries are basically injuries that occur when victims are exposed to an explosion. An explosion happens when a chemical releases pressure as well as heat. A chemical that has energy that's able to release it suddenly in the form of pressure and heat. These mechanisms, this pressure mechanism, this heat mechanism, cause injuries. We call those blast injuries. Now, like I said, it's important to remember that every explosion is from a chemical. Even gunpowder is a chemical per se. And again, this is what I like to show here in the schematic. This chemical is going to release energy in the form of pressure and heat. These are going to cause the injuries called blast injuries. Now, of course, this wave of pressure may also take with it fragments from the device or from the surrounding area of the device. These fragments can become projectiles and also cause injuries. We'll talk about that just a little bit in a few slides. But before we get to that point, I want to just draw a little bit of a comparison between two different classes of explosives, two different classes of chemicals that can explode and release a pressure wave with different speeds. We call those high order explosives versus low order explosives. Some chemicals, like gunpowder, for example, or gasoline, when they explode, they do release heat, they do release a wave of pressure, but this wave of pressure travels at a subsonic speed. Okay? This is to be contrasted with high order explosives that would also release heat and also release a wave of pressure, but this wave of pressure travels at a supersonic speed. This supersonic speed causes specific types of injuries that we call primary blast injuries. And that's unique to high order explosives. And examples of these high order explosives are C4, which is Royal Demolition Explosive, or TNT, trinitrotoluene, dynamite, which is made essentially of nitroglycerin, and even chemicals that can be used for industry or agriculture, like ammonium nitrate. Ammonium nitrate, which was the chemical that exploded in the horrific Beirut port explosion, that was a high order explosive. And again, when it explodes, we actually call it, when it detonates, the pressure wave that's released is supersonic. It will cause some specific clinical injuries that I'll tell you more about later. Contrast that to low order explosives like gunpowder or fireworks or gasoline. Those release a pressure wave that is subsonic, do not cause these primary blast wave injuries, but it does cause a release of pressure, it does cause traumatic injuries, it does cause burns, and it doesn't detonate. We say it deflagrates. Okay.
So in situations like this, there may be many people that present at the same time to a hospital. So what are some triage guidelines for events like this, and what can healthcare workers expect?
Well, that's a great question. Again, so this is a trauma incident. So, like, it's going to require trauma, mass casualty, triage, and care. Okay, so there's not a lot of differences here. But because it's an explosive incident, I always like to think about the incident in terms of three questions. What is the agent involved? What is the host of the scenario and the environment where the scenario is occurring? I call that the bomb injury threat model. It helps me better understand the casualties that I'm going to see, the injury patterns, and what to expect and how to better address them. Now, you may not know all this information at once, and some of this information will be gathered, acquired as the incident unravels. But knowing what the agent is important. Is this a ammonium nitrate, like in the Beirut port explosion, or is this fireworks? Remember, initially there was reports that the Beirut port explosion was due to fireworks. So knowing what the agent is helps us because I just told you one is a high order explosive, the other one is a low order explosive. And that can cause different severity and types of injuries. Is this a terrorist incident where someone may have added to the device additional materials like nails, ball bearings, chemicals, radioactive material, biological agents? Or is this an accident? For example, if a chemical factory has an explosion, you don't expect necessarily to have these type of added malicious materials. However, you can also have sometimes other chemicals that explode because they were just sitting in the surrounding or in proximity to the chemical that initially exploded. So understanding what was there, what was involved, how much of it, small amount, is it 10 kilograms or 2,000 kilograms? It makes a big difference. And then I like to also ask the question about the host. Who are the victims? I'd like to know, are these military units that are wearing Kevlar suits and helmets? Are they young and healthy? Or are these older people? Are these people that have children in their homes? Are these children that are involved in this? That helps us understand better the casualty patterns and also what is their access to care. Is the explosion occurring and affecting victims that have great access to care or poor access to care? Do they have hospitals at their disposal or not? And finally, where did the explosion happen? This is very important. An explosion that happens in a confined space, like a building or a house, is going to have more damage from the blast injuries. From the blast pressure waves are going to be accentuated and going to cause more severe blast injuries, particularly primary blast injuries, because this blast wave is going to be accentuated. And that increases mortality. It also can lead to structural collapse, which by itself also increases mortality of an incident. Now, contrast that with an open space environment where an explosion occurs. You have less accentuation of the primary blast wave if this was a high order explosive that's detonated. However, you can see here fragments traveling a long distance and injuries at hundreds of meters away from the device itself. So looking for injuries that are wider perimeter in an open space explosion is a wise thing to do. So these are just some useful tools to help you better understand what you're seeing, what you look for.
Yeah, it's clear that there's a lot of different factors that can go into it. And as you mentioned, we may not know all of this at the beginning. They might be kind of revealed with time, but they can kind of give us an idea of what to look for. When it comes to what to look for, are there any specific physical exam findings that we should look out for? Any specific organ systems?
Absolutely. And I think it's good. A good way to approach these, Dr. Shenoi, is to think about the different types of blast injuries. Now, I alluded to already the presence of these primary blast injuries that are due to the high order explosive releasing a supersonic blast pressure wave. I said that already. I know this may be a little bit complex, but imagine a victim is standing and surrounded in the surrounding of a high order explosive, let's say ammonium nitrate. And the ammonium nitrate detonates. The first thing that travels towards the victim is this supersonic blast wave. This supersonic blast wave is invisible. It goes through the body of the victim and it causes inflammation in the lung, in the ears, in the brain, in the eyes, in the intestinal tract. It causes pressure changes that lead to these primary blast injuries. So I want to start by talking about these primary blast injuries, the most common of which is tympanic membrane rupture, unilateral or bilateral, and presenting with tinnitus, hearing loss, vertigo, vomiting, like a regular tympanic membrane rupture would present. So screening for that is important in a blast incident. The second most common primary blast injury is the blast lung. This is not necessarily a rib fracture. This is a blast wave that goes through the lung, changes the pressures around the lung tissue, leading to inflammation, and it presents itself with cough, chest pain, shortness of breath. And on chest X-ray, you may see potentially these butterfly-like infiltrates that you see here in this child in Iraq that was published in the New England Journal of Medicine, where you see these butterfly infiltrates on X-ray as well as on CT scan. Other types of primary blast injuries include your intestinal tract injuries. Again, the intestinal tract is prone to these primary blast waves. It can cause perforations, hemorrhages. And here, remember that some of these are delayed because of mesenteric ischemia that can result from the blast wave. So screening people for abdominal pain, getting a CT scan, looking for hemorrhage or perforation. If you don't have a resource to do the CT scan immediately, watching them longer and then getting the CT scan when possible. If you discharge the patient, it's important to always tell them to come back for any new pain or persistent pain so that you can look at them again, because some of these can be delayed. Other examples of primary blast injuries include globe ruptures, which can happen. Again, those will require also screening, especially if the victim is unconscious, looking at the pupil size, pupil shape, if it's peaked, irregular, if they complain of visual loss, getting an exam of the eye, looking for globe rupture is important. And finally, head injury. You can also get intracranial hemorrhages from these primary blast pressure waves that are supersonic, traversing the body of the victims. Now, that's the primary blast injury that we covered. Other signs and symptoms, again, are related to the types of blast injuries that we mentioned. Remember, we said there are fragments. We said there are fragments that are traveling with this pressure wave at high speed. And these fragments can be sharp and can cause secondary blast injuries. You can actually have fragments that were added on purpose to the device, like nails in this victim, or they could be fragments from the surrounding area, like rocks and construction material, or glass, pieces of glass. We saw a lot of pieces of glass causing these secondary blast injuries in the Beirut port explosions. Those can cause life-threatening injuries like arterial lacerations, and so certainly can be dangerous and should be also managed, but they also should be looked for. Some of them can be subtle. If it's a nail penetrating a body, it may not be visible to the outside. Like you see here in the chest of a child, there's a small hole which is from a nail. It can be missed on secondary survey. This is why here you may decide to do some plain radiographs. The third types of blast injuries are tertiary blast injuries, and those are from the trauma. Remember, the victim now is potentially going to fall on the ground and potentially break a long bone, have a head injury. You may have a wall falling on the victim or other type of debris. All of that can cause these tertiary blast injuries. And it's important here to try to use adjuncts to diagnose these injuries, because one of the major bottlenecks of a blast injury hospital response is the radiology department. So the less you can x-ray, the more you can do ultrasounds, the better. So that's important. And some victims also, remember, can be prone to having crush injuries because they were stuck on the rubble, and their extremities may develop crush syndrome, where you can develop acidosis, hyperkalemia, and renal failure, and screening for that becomes important. Now, like I said, the bottlenecks here are going to be your radiology department and then your operating room, because a lot of these people require operating care. So again, freeing up your operation theater, calling in your surgeons. Sometimes you need to call in surgeons with specific specialization depending on the types of injuries that you are seeing. And you have to really try to triage appropriately your victims to the operating room, and possibly do like incomplete surgeries, just more like damage controlling surgeries, with secondary surgeries later on when they're stable and when you have more resources to do that. Now, but remember, in the emergency department, going back to the ER, there are only a few things that we can do to make a difference in the outcome of these victims. And for life-threatening emergencies or life-threatening injuries, there are three things we can do. One of them is the tourniquet, especially if the tourniquet is applied on the pre-hospital phase, before arrival to the hospital. That's better. A tourniquet or improvised tourniquet with a belt, like we saw in the Boston bombing, or in the emergency department, controlling this life-threatening bleeding is essential. One of the three things that we can do to change the outcome of a victim. The second one is the airway. People that lose their airway die in a bombing incident. We can put an airway, securing it, even with temporary airway, is better than no airway until we get a definitive airway. And finally, relieving a tension pneumothorax with a needle or a chest tube. These are the three things that you can do in the emergency department to go from dead to alive with your intervention. Finally, you want to consider that these crush syndrome patients, once you diagnose them, they may require operating room time for compartment syndrome compartment syndrome decompression, as well as long-term care with dialysis.
Are there any long-term effects that you might expect after they're released from the hospital later on?
Absolutely. And those are usually called your quaternary blast injuries. They're usually exacerbation of pre-existing illnesses, health conditions, particularly mental health conditions. The mental health consequences in the victims of blast injuries, as we saw in the Beirut bombing and other bombing incidents, is important. PTSD, depression, general anxiety disorder, all are very common. I also remember you may have pre-existing medical conditions that will be exacerbated, like asthma, heart disease. As a matter of fact, in the Atlanta bombing, there were two fatalities. One of them was a lady who had a nail penetrate her brain. The second one was a journalist who died from a heart attack, not from a fragment or anything like that. The heart attack was because he was exerting himself after the explosion happened and he developed STEMI. Don't forget that sometimes you have contamination of the devices with chemicals, radioactive materials, or biological agents. Those require particular special PPE sometimes. So, you have to think about that. Are you potentially seeing victims of a improvised explosive device where these agents have been added? At least wear a level D PPE, and then look for signs and symptoms that are unusual in victims. If you see people presenting with a lot of signs and symptoms consistent with a organophosphate poisoning, like a pesticide poisoning, think about nerve agents that were added to the device. If you see them presenting with a lot of cough and shortness of breath, and maybe there were chlorine added, these are chlorine bombs. Remember, radioactive material are silent, and you will not be able to see those or smell those, and the symptoms can be delayed. So in this case, what you need to do routinely on these explosive incidents is do a radiological survey, and we did that in Beirut. We did a radiation detection survey, looking for contamination with radioactive material. For the biological agent, that also will be delayed, and it's going to be hard to diagnose initially unless you are looking for this with fever and getting proper cultures and testing done on these victims. Don't forget about smoke inhalation and burns. Those are also called quaternary blast injuries. They will have a more immediate impact on the victims initially. They require also specialized care, with smoke inhalation requiring attention to hydrogen cyanide poisoning or carbon monoxide poisoning, airway compromise, and the burns, the thermal burns that require often specialized burn surgery care. As you see, it's a very complex injury complex that can result from bombing incidents, not to be taken lightly, and requires a multidisciplinary approach. And it really all starts from the pre-hospital phase, where our emergency responders, by transporting victims to the appropriate hospital from the beginning, makes a big difference in mortality of an incident, as shown in this study. For example, if you send critical victims to, if you send minorly injured victims to high-level hospitals, you will clutter the hospital and increase the mortality of that incident. Transporting less injured victims to more remote hospitals with lower levels of trauma care, is better for the overall mortality of the incident. We saw, for example, in Lebanon, 8,000 injuries and the Beirut port explosions were actually managed at a large number of hospitals, not at the major hospitals, which I think helped in improving the mortality of this horrific, tragic incident that happened in Lebanon.
Yeah, so to summarize, thank you so much. We talked about the different types of blast injuries from primary all the way to quaternary. I especially like that you mentioned the kind of emergent things that we can do from an ER perspective, which is, securing the airway, doing the needle decompression, and then also other diagnostics that we can do, such as bedside ultrasound if, the CT scanners are difficult to get to. Are there any final takeaways that you have?
No, I hope that you remember the bomb injury threat model that I described to you, the agent-host environment. I promise you that if you use it, it will help you better understand the care that you need to provide and what to look for in your patterns of injuries. I hope you can follow up with me on X at Ziad Kazi or at MENATOX. You can also email me directly at zkazi@emory.edu. And I want to thank Dr. Shenoi for organizing this important podcast.
Thank you again for joining us for Global Clinical Toxicology Series, and stay tuned for the next one.
Thank you.